Welcome, first of all, to everyone. I'm delighted that we have some new people joining us today, and part of our Bridge and HRSA web initiative. And what we're going to talk about today is really the essence of what patient care is all about. You have all in your training so far, wherever you are in the trajectory, have talked about patient-centered care. And what this age-friendly model does is really bring it home as to how do you operationalize that concept, which we struggle with a lot in our practices. So today really provides an opportunity to look at patient care. We're focused on older adults, but a lot of what we're going to talk about today has applicability in some way to all of the patients that you will be seeing, particularly your adult patients. So even though these lessons are focused on older adults, they do have some relevance to other work. So now I've got there we go. We have a whole series of modules, as Dr. Reinhardt alluded to, and you're going to have them across the spectrum of your training, depending upon how long it is, but these are all going to be available. Today's is the age-friendly healthcare and the 4 M's that we're going to be talking about. But there is a series, and these are self-learning modules that are available to everyone. Just to let you know, this is funded by the Department of Health and Human Services, mainly through the Health Resources and Service Administration, this particular project, and this explains that to you. I have no conflicts of interest. Conflicts of interest are always interesting. I was a state legislator, and my family always wondered why I never got any kickbacks, but my assignments were the state institutions and the health committee. So there weren't a lot of kickbacks for those committees. Not that I would have taken them, of course, anyway. But I definitely have no conflicts of interest with this. No one is paying me to advertise the age-friendly program. These are anachronisms, and I apologize if some of you have been through this before. So I encourage you to join us in the conversation as we go along and share your experiences with some of this. But these are terms that you will see us using throughout. And today we're going to focus on the 4 M's, but this is just for your reference. What we're going to do today is we're going to talk about what an age-friendly community and an age-friendly practice is like, using the 4 M model and what's in it. What actually do we do when we do that? And then what I hope you'll take away is 2 actions that you can actually take to your practice tomorrow or the next day, whenever you're seeing patients, that you can really begin to operationalize right away, because this is all pretty practical advice. Now, what I'd like you to do is to take, if anybody has a pencil and paper or something to jot down on, write your answer to these questions. And we're going to go back and revisit these later on. So these are the kinds of things that you're going to see in practice. Nurse practitioner is meeting with a patient. And this is the first time that she's met with this particular patient. So the question is, how does she start her discussion? And usually what we do when we go to meet with our patients for the first time is we really do a complete health history. So that's probably the most common thing. Sometimes people start with a physical exam and incorporate that into, and then talk with the patient about their care. So write down what you have seen most commonly as the first thing that people do with patients. That might be a good way to look at it. What's the first thing that you do when you meet with patients? So just jot down your answer to that question. We're going to go back and revisit it through a slightly different lens a little bit later. Here's another example. This is a PA, a physician's assistant, that's talking about meds with a patient. I'm sorry, Mr.'s name got missing somewhere in the translation of the slides. I can't remember what name I used for him, but it's on the final module anyway. But this is what we think about when we're prescribing medications for our patients. What's the most important thing? And the most important thing most of us think about is that medication going to work for whatever we're giving it to the patient for? So think about whether or not this is the right approach to use that the most important thing for us to think about is the medication's effectiveness. And again, we'll come back and revisit this in a little while. So this is Mr. Cohen. He's in the waiting room and not looking real cheerful here. And the social worker who happens to see him thinks, oh goodness, Mr. Cohen must be depressed. Let's refer him to psychiatry or to another behavioral health practitioner. We wouldn't want to see him necessarily in our primary care practice because we don't manage depression in older adults. And that's quite common. We will make those kinds of referrals. So think about that, what you think about that. Is that the right approach that this social worker should take? And the final example is this primary care provider is talking to this patient about mobility and her ability to get around. You can see that she's in a wheelchair. And the lesson here is that really only the physician should be in charge of really working to advise the patient about how to prevent falls and the effect of his medications or her medications on her ability to move around safely. So give some thought to that, whether or not you think that is the best approach that Dr. Cheng should be using. All right, so now you've got those jotted down and we'll revisit them. And I won't ask you to say what your answers were, but we'll talk about what might be different. So this is the model for age-friendly healthcare. It includes 4 different perspectives or components. And the first thing is what matters. What matters to the patient, so that when we take care of our older adults, and again, this would apply to a lot of adults, is knowing what the goals and the preferences of patients are. We talk about this, but if you reflect on practice that you've observed or what you've done, it's really kind of hard to think about that in the 15-minute visit you might have with a patient who comes to you for a particular problem, because you're trying to help them fix that problem right away. The second piece of an age-friendly healthcare involves medications. And one of the things you probably heard a lot about is polypharmacy, and we're going to talk about that in one of our sessions. But if the medication's needed, it really needs to be considered in terms of its ability to either help or hinder what matters to the older adult, how it impacts their mobility or their mentation. And we don't always think about that because we want to prescribe the drug for its effectiveness in helping the patient. And then mentation refers to the patient's mental health and looking at and preventing and treating dementia, depression, delirium, and other conditions that affect older adults and their mental health. And the final component is mobility. And our goal is to ensure that older adults move safely every day with the goal of both maintaining their function and being able to accomplish the things that they want to accomplish in their lives. So this age-friendly health system was a vision of the Hartford Foundation, and it was done in collaboration with the Institute for Healthcare Improvement, the American Hospital Association, and the Catholic Hospital Association. And this was done in response to issues within our society, including the challenges of the demographics, where we have more and more older adults as a portion of our population, recognizing that the needs of older adults, and as people were living longer, their care and their needs and their desires were often more complex than those in younger people. And that as a healthcare system, we're often not prepared to take care of older adults. And I would suggest, again, that these issues aren't unique to older adults, but they're exacerbated among older adults. And I'm sure we'll have a chance to talk about some of the things that you see that are indications of ageism in practice that you've observed or have participated in. So this is really a social movement. There are age-friendly states, New York State being one. They have statewide initiatives. Other states, Massachusetts, Rhode Island, Maine, the US Virgin Islands, to name a few. in the country. If you're really interested in the statewide initiatives, you can find them all on the AARP website. But know that New York has one. It runs out of the governor's office. And I'm going to be doing a presentation for policy people about age-friendly states. And I'll see if I can get a link so that those of you who are interested might be able to join that discussion. The important thing, like with all of our practice, but certainly in the care of older adults, really needs to follow the evidence. And we certainly have examples of how evidence is not always enough, but certainly is important in doing the right thing to help people to maintain their optimal state of health. Causing no harm, that goes without saying. But the movement also talks about aligning what matters as sort of the cornerstone to older adults and their caregivers. So our care is aligned with what people really want. We're very fond of this picture. I love the outfit. It really resonates with me. But when we're an age-friendly provider, we really operationalize those principles. So take a minute. Can anybody think about examples that they've observed with older adults where maybe the age-friendly provider or the provider wasn't age-friendly? And this isn't really meant to say that, you know, the healthcare providers are not doing what they should do. It's just that they've never learned this particular focus on this particular evidence. Does anybody have an example of anything that they have seen that they would be willing to share?
As an older adult myself, I have been addressed by other healthcare providers because I never identify my specialty as Hunt, sweetie, honey, instead of asking me what my name is.
Yeah, that's certainly something we see a lot of. I too have observed and been a victim, if you will, of that. Any of the students who have been in practice, I know my nurse practitioner student colleagues have observed because we've chatted about some of the things that we've all seen.
Yeah, I had students actually report to me that they had observed where the presumption was that the patient was not mentally stable. Basically, the patient was trying to bring forward concerns and things that were worrisome to her, and the belief was that she was just, again, having mental issues, and her complaints or concerns went unheeded. It took her a while to articulate them, so she was, you know, again, it's kind of slow to bring things forward, but the presumption that there was a psychiatric, if you will, component, which again harkens back to your earlier comments, definitely there. And the students were distressed because, again, the needs were legitimate based on their assessments.
Other? Go ahead.
Yeah, there is here. Hi, Dr. Ngo. One thing I would like to mention is that there is also, in my part, I have to be cognizant about it. The assumption that, you know, our elderly patients are hard of hearing and especially speaking louder than normal, or even sometimes slower. So that's one of the assumptions that I notice in myself.
Mm-hmm. Yeah, anybody ever observe where when somebody brings a complaint or an issue, well, you know, you are 75 years old or you are 80 years old. You know, you can't expect anything different. So my joints hurt. Well, you know, you are 80 years old. You may have heard your grandparents say that, or your parents say that. Well, you know, that happens when you get old. Okay, I gotta get my
Shirley, this is Michelle. I'm one of the NP students, and when I was doing some work in like the ICUs, we used to hear a lot of things like, you know, oh, we don't really need to do that, they're old anyway, or we don't need to consider, you know, more more life-saving treatments because they're older anyway, not necessarily that they would have poor outcomes, but that they maybe didn't deserve the work or the effort.
Yeah, great. Well, thank you for sharing those things with us. I'm not going to show this video, but it's embedded in here. So if you have an opportunity, it's from the Institute for Healthcare Improvement, and it's an overview of the 4Ms framework, essentially what we're talking about. But in the interest of time, I won't show it. It's very short. It's only a few minutes, but I think it'd be great for us to have some more conversation about these issues. So let's talk about each of these components of the age-friendly health system and what the age-friendly provider should do. Let's talk about what matters. And it provides us with an opportunity for rethinking the way in which we approach our patients. And I'd be interested to know, especially those of you who have been involved in this, if it has changed for you, the way in which you approach your patients. Any of our providers who are part of our team want to talk about how it's maybe changed their practice to illustrate?
I could just make a comment regarding, again, student feedback. What it almost does is if you practice some of these things, it almost scripts you a bit. Now that isn't, it can be confining, I guess, to have a script, and that's, not what we're all about. We should be somewhat, spontaneous and individually focused. But my point being that it kind of frames and gives you the confidence to be able to approach the patient with something to say, so that when you practice and you have all that nailed down, you can really then listen. Because part of the problem is when you're so anxious trying to, approach the patient maybe, or your part of the interaction, two-way communication, you're not necessarily able to get the other part of it, the listening part, back and concentrate and think about it in terms of, what you're doing as a provider. So the feedback being, it really helped give me the words, was the way, so that I would kind of know what to say. And I would add, again, emphasize the word practice.
Thank you, Kathy. Any others want to share their experiences and switching to what matters?
I think that, try and keep this brief. I think that, the most vital part of this model for me has been what matters, period. I think I very frequently find that asking older adults what matters to them keeps me in check. I want to do as much as I can for our patients. I want to do everything within my ability to delay the progression of their cognitive impairment and keep them in their home and safe. And sometimes my goals of care align with the patients, and that conversation is very easy. But other times, patients have very different goals and senses of what is important to them regarding medications, or an absolute lack of desire to engage in any pharmacotherapy for their cognition. And that's been the most frequent check for me to realign my prescribing practice towards what really matters to that patient. And sometimes there's a careful negotiation about what that is, if it involves behavioral symptoms that may have to be addressed for safety. But it's been invaluable. It also makes the conversation much more connected. Patients connect to us on a much deeper level when they know that we care about what is important to them. And it stops. I've said enough. Sorry.
Anybody else have a experience to share?
I mean, I've had a patient, not at SUNY, but at Kings County, who was an older adult, and she's having a lot of medical and mental problems. The only way that she was accepting our treatment and becoming connected to care was basically asking her what exactly she wants from all of this. And she had very basic needs, like some access to food. And that hooked her to the care. And then from that, she started accepting other ways of treatment.
That's beautiful. Beautiful example. So what do you?
Sometimes we don't offer what they need on the menu.
That's right. So how do you approach a patient? What do you say when you first meet them?
No, I sometimes say something very generic, like, how can I make you happier? Like, how can I please you? And make it more vague as much as possible. Because if I say, how can I help you, when I'm wearing my doctor badge, they will think I'm looking for, like, they should ask for things that pertain to what the badge that I'm wearing. So I try to go wider, like, how can I, you seem distressed, how can I take that away? And sometimes they would say the bathroom is clogged, or I don't have access to food, things like that. And then they would come back, even the visit did not entail any medical care, and they walk away with these things. They come back because they sense that they are getting things that matters to them. It's not a common scenario, but it is helpful.
That's a fantastic example of how we approach patients differently, and what a difference it makes. And I've noticed in our discussions, when we've done some of our case studies, when we go back to what the patient wants, it's always very interesting how it compares to what we think they need, and being able to reconcile those things is really at the heart, as Dr. Reinhardt pointed out, the heart of what we're all doing. So what matters really is probably the biggest change in practice. And it does take a little while to get used to how do you ask that question. And I find that just by exploring it a little bit, as was so well illustrated just a moment ago, really makes a whole difference. You know, if you say, well, why are you seeing me today? They'll give you the diagnosis that they think that, or the complaint that they think you want to hear. And I remember experience as a student in the walk-in clinic, both at the VA and in the emergency room at Yale, when what the patients told the intake coordinator was often had nothing to do why they were there. I remember a young woman who came in because she had a terrible headache, and when I saw her, she had a headache, but not a real headache. Her headache was that she was pregnant. She was scared to death about what to do, but she didn't want to tell anybody that. So the importance of really getting at what matters to the patient is really at the core of our practice. So then the medication really becomes interesting. There's the physiologic effect of the medication, and a patient who has problems with mobility, we have to think carefully about what kind of diuretic we're going to use for the patient, and how they're going to take that, and when they're going to use it. So there's a lot of things to put into the medication thing, as well as we find that polypharmacy, which you'll hear a lot more about later on, is something that really needs to be addressed in older adults. They take medications that really escalate the impact of one or the other, or counteract the effects of one another, and are a significant problem. So something that we have to pay attention to. And mentation, we often, and I've asking my older friends, do they ever get assessed when they go to see their primary care provider for their mental status or their cognitive ability? And almost without exception, everybody says no. Kathy, you're nodding your head.
Absolutely. You're right.
Yeah, and yet we're teaching all of our students, primary care and in psychiatry, that these assessments, And we teach it in nursing. I taught it to undergraduate students that when you had older adults, you need to do these screenings for different kinds of mental health issues to try to understand, because, well, they're common in our society, and there certainly are major issues for many of our older adults, and often are at the root of other problems that they may have, their ability to get out, to socialize, to interact with other people. So that's really an incredibly important piece of the screening that those of you who are preparing for primary care really will need to pay attention to wherever you may go. And then mobility, I mean, the safety issues go without saying. And again, you ask older people, does anybody ask about the safety of their environment? Now, a lot of people ask about domestic violence these days, but they don't ask about, where you live. And then, you're discharging the patient from the hospital because they have, they fractured their hip. We had a case that was presented like this, and they're on the 4th floor. How are we going to get them there? And that is really not asked of older adults routinely about, what their physical arrangements are. To say nothing about those folks who are homeless. Let's see. Matters. Oh, I guess I covered them all. Did I? Invitation, yes. All right. I thought maybe my slides were out of order. One of the other things that's really important in the care of the older adult, and that you see here today in the people that are on this call and the people that you'll be interacting with, and why we're so, we have so much emphasis on interprofessional education, is that to address the 4 M's, you really need the team. And so that's why we're trying to develop these core competencies in care of older adults that are so essential for all of you as you move forward. You will be, when you finish your program, working as part of an interprofessional team, wherever you go. Even people who have independent primary care practices need other people either to refer patients to or to work with patients. So even if your team isn't right there with you, it is an essential part of the work that you do. And these are the kinds of people that are part of the team. This is something that was described by the Boston Medical Center Geriatrics Center about what a successful collaborative practice model is all about. And one thing that's really important to remember is that the caregiver and the family are part of the team as well, and that the center of the team is the patient. And so all of us surround the patient and support the patient in terms of our care. One of the things that's often overlooked in the care of older adults is their oral health, mainly because many of my primary care colleagues don't know what to do if they identify a problem, a dental or oral health problem with their patients. So really important as you get into practice, depending upon where you work, there are some comprehensive geriatric centers, there are some comprehensive community clinics that have all of these providers as part of their team, but smaller practices don't. So that'd be one of the things to do, is find out where are those resources in the community that you can work with your patients. So let's go back to to our first examples, and let's see if we think any differently about that. So let's talk first about the nurse practitioner. So I should put a poll in here so we could poll. But does anybody want to come forward with? We'll have one of our new people come forward with which is the way that the nurse should start this discussion with Mr. Wang.
determine his personal goals.
Yes, thank you so much. Absolutely. That's where we want to begin. And we talked about that a little bit earlier about how much it really makes a difference. And that's different, I know, from how I'm always approached and have been all of my life in terms of both how I practiced, but also how I was treated as a patient. I come in with my list of my complaints and the issues that I want resolved. And they don't often get integrated in what really matters to me. You know, like I know, but nobody ever asked me. So I try to work around the system. So that's a really fundamental piece of our work. All right, so in an age-friendly provider, let's look at this next example. What should the physician's assistant be talking with, excuse me, be most concerned about in prescribing meds to Mr. X? When we prescribe a medication to an older adult, what's the first thing that we should think about?
Side effects.
Side effects? Okay.
The medication that he's already on.
The medication that he's already on, absolutely.
Is it going to help more than it's going to hurt?
Yes, it's going to help more than it's going to hurt. And also how it relates to what the patient wants to do. You know, we know that there are certain drugs that interfere with ability to have an erection. We want to be careful that if that's something that's really important to the patient, as it is to many older adults, that we have to look at the medications that we're prescribing. So that's true with anything. We think about what it is they want to accomplish and how will this medication impact that. And as excuse me, Dr. Reinhardt pointed out, it does make you think when you're prescribing a medication, what impact is this going to have and is it consistent with what the patient wants to do? Okay, in our next example, let's think about what we might do differently with Mr. Cohen. And this is a tough one for many primary care providers to deal with the mental health needs of all their patients, but particularly in relation to sorting that out among older adults. So well, maybe we can hear from our social workers. What would you do about Mr. Cohen? We have a couple of our social work colleagues on the call, Aiting and Olivia. Who's that?
So that was Cliffy, I'm sorry.
It's okay.
So, what would I do? I would actually try to speak with him first, you know, being that I am a psychotherapist myself. And then based on the conversations that I have with him, I would then let him know or let the family know if they are involved that he may need to be seen by a psychiatrist. But I always think that, you know, as a social worker, we should start where the patient is. And I think it's important to, you know, before we refer him for the social worker to speak with him.
Great. Yeah. So if you're in a primary care practice, you don't automatically want to do a referral. You want to find out a little bit about what's going on with that patient. And again, doing those screening tools that we talked about earlier for mentation and for mental health would really be great things for us to think about. And oftentimes what our primary care colleagues will say is that, you know, our visits are so short, how do we do this? And so it's a matter of incorporating into your practice some of the tools, and they become a routine part of the assessment. Some of the assessments can be done in the waiting room. They can even be done before the person comes to see you if they have access to a computerized health record or forms online. Some people send them out to people at their homes if they don't have a computer. So there are ways to do these screenings rather than in the short interview that you might have with a patient.
Dr. Girouard, I just wanted to add that in some community-based organizations, the social workers are actually the ones that do like the screening before they actually refer the patient to psychiatrists.
Yes, yes, and we have, as we've seen from some of the cases that we've discussed in some of our conferences, a lot of times what we're looking for we start with what are the possible physiologic reasons for what's impacting this patient's cognition or their mental health, and to rule out all of those physiologic concerns before you talk about mental health treatment. So, and that's something that primary care people want to do, but we often see, and my colleagues can share stories about that, we often see people who are referred because somebody's detected a problem but haven't done the kind of workup. Or the other thing that happens is people may get referred to many different providers where they make it to the right person because they haven't had that kind of opportunity to be screened effectively before they come. So this is our last example about mobility. And think about this in primary care. How would you deal with the patient's safety and their mobility during your initial interview with the patient? And let's say you're in a practice that doesn't have a physical therapist right there who you might send to. How do you deal with prevention and medication effects on mobility? I'm sure some of you have dealt with this in caring for patients in the community.
Well, we can ask them about, which floor they live on, see if we can connect them, or at least speak with their family on making things like more accessible for them, like maybe getting them a wheelchair or something like those chairs that go up and down the stairs in their home if they live on the second floor of their house, something like that.
Great. So to pay attention to the issue of stairs, to pay attention to the environment. There are some communities and some practices where they often send out a physical therapist or a nurse or someone to do an assessment of the home in relation to rugs and obstacles in the pathway. And we actually have a really great example of how patients can be prepared to change their environment so that it's safe. And we have we'll have that example, I'm sure, available to you at some point. It's a lot of fun thing to do because the importance of the environment and safety is critical. Get the rugs up, move furniture out of the way. And one of the things that has become incredibly important in looking at all of the social determinants of health, that is something that we have to work in with our communities about our housing issues. That is a major factor. And some of you, we're going to have a talk later where you'll learn a little bit about PACE, which is a program that's geared for more frail elderlies that really allows them to stay in the community and provides the kind of services that we're talking about here so people can maintain themselves in more independent living. It's an alternative to nursing homes. And there is a program in New York City that's available. That's really exciting. And we'll be talking about that more often. But oftentimes you really need to refer people for changes in housing. And one of the things that we have in Brooklyn out of the, the borough office, is there are services for older adults available in the community. And so one of our jobs as primary care providers is to make sure that if we have older adults who do have housing that's problematic to their safety and their mobility, that they can get to that particular agency for help. So think about the patients that you've seen. We came up with some great examples today about things. And probably if you reflect back, you'll think of a lot of examples where what you observe hasn't been age-friendly. And I know that we have shared some of those today. So keep these forums in mind, and you will see them quite a bit. For those of you who are in the program, you already know that, but those of you who are new to us, you will see a good deal of that. Excuse me. So think of the 4 M's as a shift in how we provide care. It really is important for us to think of it as something, a new strategy, a strategy that doesn't change our practice, but moves it in a slightly different direction. It's important to remember that the 4 M's have to be integrated. They have to be addressed together for this to work. You have a strong base upon which to work. You've talked about patient-centered care. You've talked about all the core competencies that health professionals are supposed to have. So you can build on that. So it's not a totally new concept, but it really does put the emphasis in different places. It also requires that we have some continuity in the care we provide. And I would say continuity and collaboration. That's one of the things that, that we're finding is more and more that the care that older adults get is fragmented. They are referred and referred and referred, and there's no one that pulls all those pieces together for the patient. And I think it's very difficult for anyone to be able to do that on their own. So that's a really important role of primary care and does take some effort. And there you will find that there are some agencies where they do have case management programs, especially for older adults or people with chronic complex conditions that really make a difference in pulling all those pieces together and dealing with the social determinants, which is really important. Another aspect of this is that we really need to document what we learn and what we do with the whole team so that everybody is consistent in terms of their practice. The other thing you can do is be a champion for age-friendly care. And there's a lot of ways you can do that by talking about and modeling the kinds of things that need to be done with your colleagues, whether they're students or practitioners, but to really bring that home. And one of the part of this program is for organizations to get identified as being age-friendly. And then the idea of being consistent and reliable with our patients is also an important thing to think about. So you're on the way now that you've been introduced to this concept of becoming an age-friendly provider and helping to create different practices. So whether you're working in a geriatric clinic or you're in a geriatric psych clinic or you're in a primary care setting where you deal with adult patients, keep these thoughts in mind, and we will visit this in every interaction that you have with us, talking about these essential elements. So I thank you. We have a few minutes left to have some discussion and some remarks, and here are some, where'd they go? Oh, here are some references that you can use. If you put in, and these are fairly recent, if you put the age-friendly healthcare in your search engine, you'll find all kinds of interesting things. The Institute for Healthcare Improvement is an excellent source, but the American Hospital Association, WHO, and there are some journal articles that are helpful. The other thing, and we'll talk about that more later, is that there is evidence that age-friendly programs are actually cost-effective as well as quality-effective, both for providers and for patients. So in the last few minutes that we have, any thoughts, comments, ideas, issues?